My name is Sekhar, and I'm an associate professor of radiology at Emory University. The main contraindication for liver-directed therapy is having poor liver functioning. Because these therapies either reduce the arterial blood supply to the liver or they cause radiation necrosis of a region of the liver, you need to have sufficient liver functioning to allow the liver to recover from these therapies and maintain all of the normal processes that the liver performs. So careful patient selection is essential. This is where a multidisciplinary tumor board is absolutely essential for these patients. One of the main contraindications is if the liver function is poor, such as a child C patient or a patient who has a bilirubin greater than 2 or an albumin less than 3. Performing these therapies on patients with poor liver function at baseline can cause liver failure. Other contraindications include shunting. So we perform studies ahead of time to see if there are any blood vessels that are supplying the tumor that might be also supplying other organs. It is rare to have this kind of complication these days because we perform extensive planning before the surgery, before the procedure. And we also do cone beam CT during the procedure so we can see exactly where the embolization material is going and where the radiotherapy particles are going. But rarely we can have some of this off-site non-targeted therapy going to the stomach, the gallbladder, other organs. But as I said, this is rare these days. Another complication that can happen is post-embolization syndrome. This is pretty common, and it is flu-like symptoms after embolization. And this is thought to be due to the tumor necrosis and the radiation necrosis. This can consist of nausea, vomiting, fever. Occasionally, patients have to come back to the hospital for supportive care, but this is self-limited and usually only lasts 4 to 6 days. Another relative contraindication is having tumor in vein or tumor that is residing within your portal vein, your main portal vein, your right or your left portal vein. This was a very challenging situation previously, especially for TACE or TAE, because they are embolizing the hepatic arteries and reducing the blood flow from the hepatic artery. And if you already have tumor within your portal vein, this now reduces both your portal venous supply as well as your hepatic arterial supply and can lead your liver to become ischemic. However, now that we can do even more selective targeted radiation therapy to very, very small areas of the liver, we're able to perform, for example, Y90 radiotherapy, even in patients who have extensive portal vein thrombus. So this is an advancement that we've recently gained, and it has become not an absolute contraindication, but a relative contraindication if you have tumor within your main portal vein. There's also been increasing data coming out about how to perform personalized radiodosimetry. And this has allowed us to target smaller areas with this Y90 radiotherapy. And because of this, Y90 is becoming a preferred technique at many institutions across the country. But the choice of technique is really institution dependent and is dependent on the discussion at the tumor board about the baseline liver function and what is the best therapy for a certain tumor. One more contraindication for these therapies is if there's extensive extrahepatic disease, in which case systemic therapy such as sorafenib may be preferred, or if there's too much liver burden throughout the liver and this therapy is not going to result in sufficient remnant hepatic function.